Hyperlipidemia is a major cause of atherosclerosis and atherosclerosis-induced conditions, such as coronary heart disease, CHD, ischemic cerebrovascular disease, and peripheral vascular disease. Although the incidence of these atherosclerosis-related cardiovascular disease, CVD, events has declined in the U.S. These conditions cause morbidity or mortality in a majority of middle-aged or older adults and account for about 1/3 of all deaths of persons in this age range. The incidence and absolute number of annual events will likely increase over the next decade because of the epidemic of obesity and the aging of the U.S. population. Dyslipidemias, including hyperlipidemia, hypercholesterolemia, and low levels of high-density lipoprotein cholesterol, HDLC, are major causes of increased atherogenic risk. Both genetic disorders and lifestyle, sedentary behavior and diets high in calories, saturated fat, and cholesterol, contribute to the dyslipidemias seen in countries around the world. For many individuals, alterations in lifestyle have a far greater potential for reducing vascular disease risk and at a lower cost than drug therapy. When pharmacotherapy is indicated, providers can choose from multiple agents with proven efficacy. Statins. The statins are the most effective and best tolerated agents for treating dyslipidemia. These drugs are competitive inhibitors of hydroxymethylglutarol coenzyme A reductase, 3-hydroxy-3-methyl-glutarol coenzyme A reductase, HMG-CoA reductase, which catalyzes an early rate-limiting step in cholesterol biosynthesis. Higher doses of the more potent statins, e.g., atorvastatin, simvastatin, and rosuvastatin, also can reduce triglyceride levels caused by elevated very low-density lipoprotein (VLDL) levels. Some statins also are indicated for raising HDLC levels. Although the clinical significance of these effects on HDLC remains to be proven, multiple well-controlled clinical trials have documented the efficacy and safety of simvastatin, pravastatin, lovastatin, atorvastatin, and rosuvastatin in reducing fatal and non-fatal CHD events, strokes, and total mortality. Rates of adverse events in statin trials were the same in the placebo groups and in the groups receiving the drug. History. Statins were isolated from a mold, Penicillium citrinum, and identified as inhibitors of cholesterol biosynthesis in 1976 by Endo and colleagues. Subsequent studies by Brown and Goldstein established that statins act by inhibiting HMG-CoA reductase. The first statin studied in humans was compactin, renamed mevastatin, which demonstrated the therapeutic potential of this class of drugs. Alberts and colleagues at Merck developed the first statin approved for use in humans, lovastatin, formerly known as mevanolin, which was isolated from Aspergillus terreus. 6 other statins are also available. Pravastatin and simvastatin are chemically modified derivatives of lovastatin. Atorvastatin, fluvastatin, rosuvastatin, and pitavastatin are structurally distinct synthetic compounds. Mechanism of action. Statins exert their major effect, reduction of low-density lipoprotein, LDL, levels, through a mevalonic acid-like moiety that competitively inhibits HMG-CoA reductase. By reducing the conversion of HMG-CoA to mevalonate, statins inhibit an early and rate-limiting step in cholesterol biosynthesis. Statins affect blood cholesterol levels by inhibiting hepatic cholesterol synthesis, which results in increased expression of the LDL receptor gene. In response to the reduced free cholesterol content within hepatocytes, membrane-bound sterol regulatory element binding proteins, SREBPs, are cleaved by a protease and translocated to the nucleus. The transcription factors then bind the sterol responsive element of the LDL receptor gene, enhancing transcription and increasing the synthesis of LDL receptors. Degradation of LDL receptors also is reduced. The greater number of LDL receptors on the surface of hepatocytes results in increased removal of LDL from the blood, thereby lowering low-density lipoprotein cholesterol, LDLC, levels. Adverse effects and drug interactions. Hepatotoxicity. Initial post-marketing surveillance studies of the statins revealed an elevation in hepatic transaminase to values greater than 3 times the upper limit of normal, with an incidence as great as 1%. The incidence appeared to be dose-related. However, in the placebo-controlled outcome trials in which 10 to 40 mg doses of simvastatin, lovastatin, fluvastatin, atorvastatin, pravastatin, or rosuvastatin were used, the incidence of 3-fold elevations in hepatic transaminases was 1 to 3% in the active drug treatment groups and 1.1% in placebo patients. No cases of liver failure occurred in these trials, although serious hepatotoxicity is rare. 30 cases of liver failure associated with statin use were reported to the Food and Drug Administration, FDA, between 1987 and 2000, a rate of about 1 case per million person-years of use. It is therefore reasonable to measure alanine aminotransferase, ALT, at baseline and thereafter when clinically indicated. Myopathy. The major adverse effect associated with statin use is myopathy. Between 1987 and 2001, the FDA recorded 42 deaths from rhabdomyolysis induced by statins, excluding rosuvastatin, which has been withdrawn from the market worldwide. This is a rate of 1 death per million prescriptions, 30-day supply. In the statin trials described earlier, under hepatotoxicity, rhabdomyolysis occurred in 8 active drug recipients versus 5 placebo subjects. Among active drug recipients, 0.17% had creatine kinase, CK, values exceeding 10 times the upper limit of normal. Among placebo-treated subjects, the incidence was 0.13%. Only 13 out of 55 drug-treated subjects and 4 out of 43 placebo subjects with greater than 10-fold elevations of CK reported any muscle symptoms. The risk of myopathy and rhabdomyolysis increases in proportion to statin dose and plasma concentrations. Consequently, factors inhibiting statin catabolism are associated with increased myopathy risk, including advanced age, especially greater than 80 years of age, hepatic or renal dysfunction, perioperative periods, multi-system disease, especially in association with diabetes mellitus, small body size, and untreated hypothyroidism. Concomitant use of drugs that diminish statin catabolism or interfere with hepatic uptake is associated with myopathy and rhabdomyolysis in 50 to 60% of all cases. There are a variety of pharmacokinetic mechanisms by which these drugs increase myopathy risk when administered concomitantly with statins. Gemfibrozil, the drug most commonly associated with statin-induced myopathy, inhibits both uptake of the active hydroxy acid forms of statins into hepatocytes by organic anion transporting polypeptide 1b1, OATP1b1, and interferes with the transformation of most statins by glucuronidases. Primarily due to inhibition of OATP1b1-mediated hepatic uptake, co-administration of gemfibrozil nearly doubles the plasma concentration of the statin hydroxy acids. Other fibrates, especially fenofibrate, do not interfere with the glucuronidation of statins and pose less risk of myopathy when used in combination with statin therapy. Concomitant therapy with simvastatin, 80 mg daily, and fenofibrate, 160 mg daily, results in no clinically significant pharmacokinetic interaction. Similar results were obtained in a study of low-dose rosuvastatin, 10 mg daily, plus fenofibrate, 67 mg 3 times a day, when statins are administered with niacin. The myopathy probably is caused by an enhanced inhibition of skeletal muscle cholesterol synthesis, a pharmacodynamic interaction. Despite the rarity of tenfold elevations of CK, many patients complain of muscle aches, myalgias, while taking statins. It is unclear if such myalgias are caused by taking a statin. In one clinical trial involving 20,000 subjects randomized to simvastatin, 40 mg daily, or placebo, it was observed over the 5 years of the study that 1/3 of patients complained of myalgia at least once, whether the active drug or the placebo was being taken. Replacing vitamin D in patients with a vitamin D deficiency reportedly reduces statin-associated myalgias and improves statin tolerance. The observation needs to be confirmed, but it is potentially significant because vitamin D deficiency is associated with myopathy, insulin resistance, and increased incidence of CVD. Pregnancy. The safety of statins during pregnancy has not been established. Women wishing to conceive should not take statins during their childbearing years. Women taking statins should use highly effective contraception. Nursing mothers also are advised to avoid taking statins.